So I'm going to talk about a very different application, and I think obviously it's one that we're all personally familiar with because cardiovascular disease impacts each of our lives, and certainly all of us are concerned about how blood flows through our arteries. I want to acknowledge just briefly some of the students, staff, and alumni from my lab who contributed to this work. So what I'm going to tell you about today is I'm going to briefly give you a little bit of background about kind of motivation for why we want to quantify flow and pressure in the circulation, talk about some of the limits of the current paradigm, really a diagnostic empirical paradigm to practicing medicine, really largely based upon diagnostic imaging technology. I'll talk about the idea of fusing imaging technology with computational fluid dynamics and computational mechanics in general, show a couple of examples, talk about fluid structure interaction, why we're interested in that, and then just close with some verification, validation, work in progress, and closing remarks. So just a little background. Cardiovascular disease manifests as vascular diseases, including atherosclerosis and aneurysms. And the leading cause of death in the U.S. is heart disease, and that really is primarily because of blockages in the coronary arteries, atherosclerosis in the coronary arteries, that then reduces the blood supply to the heart, the muscle of the heart, and that's the primary cause of heart attacks. Stroke, which is a third leading cause of death in the U.S., is principally due to atherosclerotic disease in the carotid bifurcation. So in your neck on either side, the common carotid artery branches into the internal and external carotid artery, and there's a very focal location in the carotid sinus where atherosclerotic disease develops. As that becomes progressively narrowed, the plaque could become ulcerated, and a portion of the plaque could break off, float downstream to the brain, and cause a stroke. It could either be a plaque or it could even be a blood clot related to an ulcerated plaque. So the opposite problem, not where vessels become progressively occluded, but where the wall of the vessel weakens, is a problem of aneurysms. And aneurysms develop in the thoracic aorta, the abdominal aorta, and the cerebral circulation. And there are many different risk factors, and I unfortunately don't have time to talk about all the risk factors related to these, but we'll talk about kind of the fluid mechanics issues related to the progression, development, and ultimately understanding treatment of these diseases. Incidentally, Albert Einstein died of a ruptured abdominal aortic aneurysm. So what is the connection to blood flow? Well, most of the risk factors for cardiovascular disease, and this is true for atherosclerosis and aneurysms and other disease, are systemic. A disease like atherosclerosis, however, is very focal in nature. I showed that example in the common carotid, the branch of the common internal and external carotid artery, a very focal narrowing. And it's through experimental fluid mechanics techniques, visualization techniques, laser Doppler anemometry, and other techniques. The pattern of flow in the carotid bifurcation was delineated. And it was noted that with this an idealized model, but flow would separate. This is a steady flow visualization, but flow would separate. We have a recirculation zone. And this is exactly where plaque develops in the carotid sinus. There was a lot of debate as to whether it was high forces that were stripping the cells lining each of our vessels off, or whether it was flow stagnation, high residence time of low density lipoproteins that ultimately led to it. But it's pretty conclusive now. The data shows that it is areas of flow stagnation that occur in the body that are localized, where atherosclerosis localizes. And what we now know is that if you expose cells, that endothelial cells line every single blood vessel in our body, from our large arteries down to our capillaries. And these endothelial cells are really the barrier. They're the barrier between the bloodstream and the vessel wall, and they have an important barrier function, certainly preventing ingress, for instance, of lipids, other substances into the vessel wall in the large arteries. And under high shear conditions, the endothelial cells become aligned with the direction of flow. The gap junctions between the cells is smaller. In areas of flow stagnation, there's no preferential orientation. The junctions between the cells are larger, permitting a greater ingress of cholesterol or low-density lipoproteins into the wall. The adhesiveness of the endothelial cells to other cells circulating through the body that contribute to the atherosclerotic process is affected by flow. So to sum it up, high flow conditions generally atherosclerosis is inhibited and areas of low flow or low shear atherosclerosis is promoted. In addition to that, high flow activities like exercise, for instance, is thought to have a potential benefit by, for instance, aligning endothelial cells, changing endothelial cell structure, and promoting cardiovascular health. So that's atherosclerosis. The other area that I want to talk about is what happens, at a much earlier point in some people's lives, and that is the problem during development, the problem of congenital heart disease. Congenital heart disease is a structural problem with the heart or the great arteries that are present at birth. It's the most common birth defect, and the number one cause of death due to birth defects affects about 1 in 100 newborns. And it's pretty remarkable. It's not widely known, but twice as many children die of congenital heart disease as all forms of childhood cancer. So what are some of the problems that are encountered? This is a problem that we've studied. We have a clinical study going on right now. It's a problem of aortic coarctation. Here is the heart. The oxygenated blood is oxygenated. It's shown in red, and deoxygenated blood is shown in blue. Blood, as it's pumped out of the left ventricle into the aorta, comes down through the aorta, and patients with aortic coarctation have an area where the aorta is actually narrowed. And that creates an obstruction, sometimes very significant obstruction, that ultimately the heart has to overcome to be able to pump blood down to the rest of the body. And the result of that is blood pressure in these patients is much higher. The heart has to do much more work, etc. And I'll talk more about this condition later. This is a different problem, and a problem, it's called single ventricle, is a single ventricle disease. And in this case, one of the ventricles did not develop properly, and there's, I've just shown here complex surgical reconstruction that's done in these patients with this type of problem. So one ventricle is not functioning, and surgeons have to basically reroute blood throughout the body so that single functioning ventricle can pump blood first to the systemic circulation, then passively through the lungs, and then back into that single functioning ventricle. It's kind of like a fish heart in some ways, single pumping chamber. But of course the patients don't have gills for oxygenation. So what is the connection with blood flow? So some congenital heart diseases result in significantly increased cardiac output, and the vascular system adapts to that. This is a really dramatic example. This is of what happens when you have a ventricular septal defect, which is the most common congenital heart defect. So a hole between the chambers, between the ventricles. This is a chest x-ray of a normal heart. This is a child with an enlarged heart. This is basically taken up the entire chest cavity. And the heart has adapted and changed due to the higher demands of flow. It's an inefficient pumping system. It has to basically, try to, pump out, an extraordinary level of flow because some of it is basically lost through this pathway. So this is called volume overload hypertrophy. Other problems, for instance, as would manifest with this aortic coarctation, is that the ventricle has to work a lot harder, and the problem associated with that is that it's like a muscle. The heart's a muscle. If it has to work harder because it has to overcome a higher pressure, the wall of the ventricle hypertrophies. It gets very thick. So the inner chamber where blood is stored and ejected gets progressively smaller. So there's a progressive thickening of the vessel wall that can lead to heart failure. Other issues are when, and this is just an example where a child has, this are the pulmonary arteries, and he has an obstruction in one of the pulmonary arteries, and the left lung is underdeveloped. And I've seen patients that have about 10% of the pulmonary flow goes to one lung and 90% goes to the other. And this is just due to the fact that blood is following the path of least resistance, and if there's a high resistance vascular bed, then that organ will actually not develop properly. So pediatric cardiologists simplistically say no flow, no grow, but it's just a way of thinking about the fact that our entire body is affected by how much blood is flowing through it. So how does fluid mechanics factor into this? Well, whether it's a bypass surgery or this is a new type of repair for treating an abdominal aortic aneurysm, the success of the treatment directly depends upon the flow rate through the affected arteries and the hemodynamic forces, including pressure and shear. Whether this bypass graft is successful or whether a patient needs a double, triple, quadruple, quintuple bypass or not is going to depend in part upon how successful this procedure is, or whether the surgeon thinks that this procedure is going to provide adequate flow to the muscle of the heart. This is a case where the stent graft is placed. It's a minimally invasive way of treating an aneurysm. This is post-implantation. This is how the device is actually migrated and moved down inside of the aneurysm after a 3-year follow-up. And we have an NIH grant to look at basically why some devices migrate and some other devices don't within the kind of overall comparative effectiveness initiative at NIH. So what are our tools? What is the information that we have available to us to understand the circulation? So we have extraordinary tools for medical imaging. We have diagnostic tools to look at the coronary arteries. This is a bypass graft actually all the way from the axillary artery up in the shoulder all the way down into the groin. This is just an image of the carotid and vertebral arteries. So we have these extraordinary tools, but the limitation is we get exquisite anatomic data, but very little information on physiology or flow. Blood flow rate, blood pressures, etc. We observe disease, but we have to rely on empirical data from other people to predict how it will progress. We observe and monitor implanted devices, but we can't get information about force acting on them. And importantly, we observe the effect of a given therapy on the health of the patient, but can't predict the best treatment a priori. And this is, I think all of you that work in many other fields, engineering fields, we had a wonderful talk about the applications of engineering CFD and aeronautics, and we kind of take that for granted. But imagine if you had no computational tools and no analysis tools for that matter, how would people be building airplanes? Well, they'd be building it like it was done, many, many years ago when that was really all that was available to us. So what is medicine? So what is this paradigm, this diagnostic paradigm? The problem with it is that you're figuring out whether this procedure works on a person. It's not like having something that fails in a wind tunnel or some other test. If this procedure fails, it could mean someone's life. And this is a cartoon from the New Yorker, an example of the very same procedure when done correctly. This is the fundamental flaw with how medicine, quite frankly, is practiced in today's day and age. So what we've tried to do is to develop tools that could actually give some insight. And really the emphasis is on the ability to actually predict outcomes and to be able to get information before a surgeon goes into the operating room or a cardiologist is deciding how to treat a patient. Quantitative information and predictive models for how the circulation might be affected by a proposed intervention. So governing equation, this is just obviously very simplistic. I'm just looking at kind of linear elastodynamics equations in general, but just thinking about how fluid and solid domains are coupled, and I'll talk more about that later. So how has this field been impacted by CFD? Well, some of the early work that was done was really kind of replicating some of those experimental tests that were done to understand localization of atherosclerosis, understand flow patterns in the arterial system. And they really did augment the experimental data that was available. But there are a lot of simplifying assumptions. The walls are generally assumed rigid, the geometries were simple, and boundary conditions were highly idealized. Our previous speaker spoke about the importance of the outflow boundary conditions, and for us in the circulation, we have pressure and flow waves going through our arteries at any time. If we want to abstract part of the circulation, take the large arteries for instance, we have to pay attention to what's upstream and what's downstream, because there's no way to predict flow distribution of pressure if you don't pay attention to that. Unfortunately, we cannot have a boundary condition which is, for instance, absorbing, because pressure waves go down to the periphery, to the microcirculation, get reflected back, and have a dramatic influence on pressure and flow in the large arteries in our computational domain. So we've had to think about new approaches. But there really, the classical approach to solving these problems, there really was not an ability to predict and model the wave propagation phenomena, or really predict flow or pressure at realistic levels. So I started working in this. It was really kind of a remarkable event for me, because it was really at the time I was a graduate student at Stanford, and it was the very early days of seeing 3D CT technology that was available. And this is one of the first data sets I saw of a patient with an abdominal aortic aneurysm. This is obviously their skin, the aorta's in there, this pink area is a clot, yellow are calcifications. And what I realized is that we've been doing models of flow through idealized geometries. And I thought, well, if we could actually kind of build a geometry from medical image data, then we could get information about, do more realistic CFD simulations and understand forces and aneurysms. And this is some of the early work that we did in that time period. What I also realized is that we could then use these tools to try to do prospective planning and prediction, and we started thinking about this idea of this is a surgical sketch pad where this is just a 2D sketch pad, and this really kind of was more of a demonstration than anything else, but it was a demonstration to a group of vascular surgeons, and these are two vascular surgeons that were sitting in front of workstations and using the sketch pad and planning an intervention, and anyways, it was just mostly for show, but it was to try to illustrate, what is the potential of using these types of tools. So what we've been doing in the years since is really developing tools to build models from image data. We don't have a CAD file. We can't construct a geometry from that. We have to actually pull it out of the image data. So we use techniques, for instance, like level set methods, other methods for finding boundaries, doing image segmentation, finding structures. That might mean finding lumen boundary. That might be finding outer wall, finding calcifications, other things like that. So that's the first part of the problem. The other issue that I talked about is how do we solve with more realistic boundary conditions, and I'll come back to that, but essentially what it is, it's understanding, having a model for the downstream or upstream domain that is a physics-based model, but it's a reduced order model. It's not, because we can't solve Navier-Stokes equations or even if those were the appropriate equations for these types of fluids, we can't solve that in the entire body. We have to abstract, and the boundary condition issue becomes really important, and I'll talk about that. Discretization, we're often long tubular structures, and we've had to develop kind of boundary layer mesh generation strategies, adaptive mesh generation strategies that are appropriate. And then these are often very big problems, the pulsatile flow through these types of systems, and we develop parallel CFD solvers. So this issue of image-based versus versus generic models. This is about the level of resolution we can see somebody's pulmonary arteries, and this was the child that I told you about with an obstruction in the left pulmonary artery. But the problem is what we don't see is most of the circulation. Most of the circulation, all this kind of beautiful branching patterns and the high resistance vessels are downstream. They're beyond the limits of image resolution, so we have to have a model for that. So we can use, for instance, we can look at other species, for example. We could take from cadavers, do casting of people's lungs, and then make measurements to see what those branching patterns typically look like, and infer and try to devise an appropriate generic model or downstream boundary condition model based upon that. This is work that we did in my lab to basically look at the rat pulmonary arteries, and this is about a 12 micron resolution. To be able to look at just what the branching patterns look like to get some understanding of what our branching patterns might look like. And I should say that there's kind of remarkable similarity, across species and many phenomena. The issues of scaling of fluid flow, heart rate, with allometric scaling laws are really widely applied in this area. So what do? So we have three-dimensional techniques, and this is three different approaches for the coronary tree. This is some work from my lab, the 3D methods. This is a 1D wave propagation model, and this is a simple lump parameter model. So we have different ways of understanding and describing the fluid flow phenomena. This is really basically solving 1D wave equations, nonlinear wave equations. This is just a simple electrical analog where resistance is used for viscous resistance. A capacitor is used to simulate compliance effects. We use inductor for inertial effects, diodes for heart valves, etc. You get the basic idea. Very simple approach that can be used. So we can't model the whole problem with the 3D domain. So what we try to do is to use reduced order models, as I was saying, the outlets. And then, for example, if we want to model the pulmonary tree at every outlet, we basically classify the size of the vessel, and we say what is it most likely? What does the branching pattern most likely look like? And we use this is actually 7 of 15 generations of a model based upon vascular casting data, and then we use linear wave propagation theory in that model to compute an impedance of the whole tree, vascular impedance of the whole tree, and then use that as a boundary condition at the outlet. So we have totally different types of boundary conditions and maybe some of the ones that are used in other areas. And the approach that we've developed is we call the coupled multi-domain method, and we're using final methods. So if we look at a weak form, we have basically a multi-dimensional weak form that has boundary operators that factor in the mathematical model of what's downstream. So those of you who are familiar with like Dirichlet to Neumann methods or other methods, it's a very similar approach. I was really inspired by that type of work where the boundary operators act on the boundary and they're solved with the governing system of equations, but they reflect the physics of what's downstream. So then the challenge becomes, how do you develop boundary operators? So what we generally do in our simulations, we have flow rate. Generally we prescribe flow rate on inlet. We'll have often a resistance boundary condition. So we're not enforcing pressure or flow, but we're enforcing, in this case, a linear relationship between pressure and flow, or a more complex relationship. This is relating flow to pressure in the admittance, which is just the inverse of the impedance. And then we compute the impedance using linear wave theory or some other approach. I'll just tell you quickly, what is the importance of boundary conditions? So this is a very simple problem that we solve. So this is a problem where we have just a elastic vessel. We have an inlet flow, and then basically the wave is going to propagate down to the outlet. And at the inlet, we prescribe a flow rate. Okay, so it's a prescribed flow. And what we would expect to happen in this problem is that this inflow would basically propagate down the length. So that's the inflow condition. At the outlet, what we can do, we could specify constant pressure, for example. We could use a relationship between pressure and flow, the linear relationship with resistance. Or we could use a more sophisticated impedance model that models the wave propagation phenomena downstream. And I'll just say, suffice it to say is that when you use the impedance approach, then you see the expected, basically, propagation of the wave downstream. This is the impedance wave that's been slightly damped. There's damping and dispersion of the wave as it goes down the length. And then the pressure wave at the inlet is realistic, and it's very similar to the pressure wave at the outlet. And the other boundary conditions basically fail miserably in that regard. So really you have to account for the wave phenomena downstream in order to model the waves upstream. This is just an example of how we applied this. This is a clinical case, and this is a child who had a disease called tetralogy of flow. And one of the manifestations of that is a restriction in the left pulmonary artery. And the basic question the surgeons had is that would this child benefit from a surgery to remove this obstruction right there? Well, the risk was it was an invasive procedure, and there was just a question of would there be a benefit to that. So we did an analysis of this with and without the obstruction using our boundary conditions were impedance-based boundary conditions. What we showed is that essentially removing this obstruction would have no impact on flow and pressure. And the reason for that became clear afterwards, and it was because the fact that what has happened, this child probably had this from about the age of 1. They were 16 years old when they presented in the clinic, and what happened is that the entire development of the left pulmonary artery arterial tree changed. It was affected by that obstruction. So the right pulmonary tree has numerous branches. They're all in parallel, so the effective resistance of the right pulmonary tree is much lower than the left. This resistance to flow is small compared to the downstream resistance of pushing flow through the microcirculation. So that was a case where there was really no hemodynamic benefit for doing that type of intervention. And that's an example of how we use these tools. Let me show you another example of pulmonary flow because this is so important in patients with congenital heart disease. And this is a model we constructed from magnetic resonance imaging. And we looked at a group of patients, a group of normal subjects and patients with some pulmonary disease. Here's a discretization. So we wanted to understand flow at rest and exercise, and actually to get information about exercise. I do a lot of experimental work in my lab. We don't use laser Doppler anemometry or PIV or anything like that because we're really interested in understanding flow in vivo in the body. So we use techniques like MRI and phase contrast MRI, and this was a study we did to measure blood flow while subjects were, in children in this case, were riding a bicycle inside the MRI, and we developed the techniques to measure their flow and compute flow at rest exercise. So that's what we use for the input boundary conditions, and then here's just a picture of the flow at rest and exercise. What we're doing to represent the flow velocity patterns, we're just volume rendering the velocity magnitude, the speed field, and it just gives us a qualitative picture of what's happening in the different parts of the circulation. And it's just, again, it's only qualitative at this point, and a qualitative view. Obviously, we have the velocity and pressure fields that we can compute other things from. For example, like wall shear stress to be able to look at rest and exercise conditions, and these are two different subjects. And then we can do a study over groups of patients to be able to say, statistically, what is unique about stress in the pulmonary circulation versus other parts of the body. And what we learned from this is we have another explanation as to why pulmonary arteries are really resistant to the development of atherosclerosis, and in part that's because their surface forces are much higher. The shear forces are about 5 times higher than what you see in parts of the systemic circulation where disease is prevalent. Just another quick example where we're using these techniques to actually test out a new therapy for patients with aneurysms. And this is actually, the therapy is simple, but it's never been applied. It's actually exercise, to look at the benefits of exercise in patients with abdominal aortic aneurysms. So we'll get anatomic data, build models, gather physiologic, functional data for boundary conditions. Here's 40 patients with small aneurysms. And then simulation will simulate flow at rest, mild and vigorous exercise. So in this case, we can get insight into a physiologic condition that would be very difficult to measure. We can't actually measure higher intensity levels of exercise in an MRI because the person's moving around too much, nor could we even get any insight into the fields, to try to understand velocity patterns in fields with just the experimental techniques. And we're looking at, this is just looking at some resonance time, and we're looking at how aneurysms of different geometry, different shape, have different resonance times. And the reason for that is to understand how clot develops, thrombus develops in aneurysms, because it's thought that as you have an increased thrombus burden, that basically enzymatically degrades the wall underneath it, and leads to a progression of aneurysm. So our theory as to why exercise will be important is actually that the relatively weak turbulence that would develop under these conditions of exercise basically would eliminate areas that are chronically stagnant under resting conditions and hopefully slow the growth of thrombus. And we're doing a clinical study where we have patients that were imaged when they enrolled and that are being imaged at 3-year intervals. So we're just starting to do the follow-up studies in these patients, and hopefully we'll learn something about, maybe this is a beneficial for patients with these small aneurysms. So I want to just tell you quickly about fluid-structure interaction, and there's a lot of reasons for understanding it. It could be the effect of the velocity field. Certainly we can't understand pressure adequately, affects cardiac work, the biology of the vessel wall, and may be important in disease progression. So again, looking at fluid-solid domain, what we did is we had an idea of actually, it came about, and I'll tell you briefly later, there's an analytical solution for pulsatile flow in elastic vessels. And the idea behind it was really just basically taking a traction force, a lateral traction force, and imposing a fictitious body force in the elastodynamics equation, and then relating it, provided that you have a thin wall assumption and you have basically a linearized approach, then you can relate the traction to the body force and essentially embed the elastodynamics equations into the fluid mechanics equations at a variational level. And this has a huge advantage because we could solve very large-scale fluid structure problems, albeit subject to these limitations, where we can start to look at the interactions between complex flow, wall dynamics, pressure fields, etc. And that's an idealized aortic coarctation. You can't do this with, in my opinion at least, with an ALE method for incompressible flow and slender elastic structures. So here's an example of how we're applying that as the problem of aortic coarctation that I told you about. And importantly, the average lifespan, even after the surgical repair, is about 35 to 50 years. And the reason is that they have very severe obstruction in their aorta. They have high pressure above that increases risk of heart failure, hypertension, aneurysms, stroke, etc. And also affects the flow of blood to the coronary arteries themselves. It's a pretty significant condition. This is a model of a patient pre-op, pre-intervention, and then simulated post-intervention. And how we did this model is that there's a lot of detail that's not important, but I'll just tell you at all the outlet boundary conditions. In this case, we use a simple 3-element lump model at the outlets At the inlet, we actually use a model, lump parameter model for the heart. So in this model, we don't ever prescribe pressure flow anywhere in the domain. We actually have, through the coupling of the heart model and the 3D domain, we get the flow and pressure in the vascular model, and then the pressure is also set by the level of downstream resistances and compliance. So it's a very different approach. In this case, what we're doing is the simulation pre-intervention, the pressure, wall dynamics, and velocity field, and then this is post-intervention. The reason why this is important is that a person like this, it's pretty clear that this person needs an intervention. But in many times it's not so clear. There's some narrowing, but you want to know whether you go in there and surgically repair, the aorta. This is a very serious operation, and there's a need to know whether there'll really be a benefit. Sometimes a patient gets an operation like this, and then there's some subsequent re-narrowing, and the surgeon wants to know, is there a benefit to a reoperation or another repair? So those are questions we're trying to answer. Lastly, I'll just tell you about cerebral aneurysms, and this is an important problem, and one where there's really been a lot of attention in the biofluids and the CFD community to understand. And the reason there is that cerebral aneurysms, if you are lucky enough to actually be diagnosed with a cerebral aneurysm before it ruptured, I mean, you're not lucky to get it, obviously, but if it's diagnosed, that's helpful. But the problem is the risk of rupture is about 5%. If this is diagnosed. And the problem is you do not know as a patient whether you're in the 5% or the 95% group, right? So there's a lot of interest in, a rupture of a vessel, a rupture of an aneurysm, there's some mechanics likely involved in that, right? The kind of tearing of the wall. And there's a lot of interest in trying to understand that. And this is just an example of modeling flow into the circulation in the aneurysm. And this also points out, actually, one of the problems when you go into the fluid structure problems, these elastic structures, you have to think about external tissue support and things like that, in this problem we haven't modeled yet. Here's another example of modeling from the arch all the way into the brain. We're starting to use these tools now together, the fluid structure interaction, with models of growth and remodeling to model basically the disease process itself and the changes in the vessel wall. So I'll just tell you, I want to quickly about verification validation. I was telling you about the Wormersley's elastic tube theory, the analytical solution, the steady oscillatory component for pressure. There's axial velocity to the radial velocity. It's I sometimes derive this in class in one of my PhD level courses. It takes me about 2 weeks or so to go through it. It's not a pleasant experience for some of the students necessarily, but it's about as sophisticated of an analytical solution as we can come up with. In the theory, basically, if you have a pulsatile flow rate, in this case, this tells you what the axial velocity variation is over the cardiac cycle. And it's very useful from a verification perspective for codes. And this is just a comparison of our fluid structure methods, which are the dots versus the solid lines, which are the analytical solution. So we're very pleased to see that we had, very good agreement. And this is the flow and pressure waves for that problem. In vitro validation, we tend to build physical models and use MR-compatible flow systems to do studies using our velocity measurement techniques that we use in vivo, MRI techniques, and we've done some in vitro validation work, some animal work to do in vivo validation, and I'll kind of skip over that in the interest of time. Tell you about work in progress. One of the challenges we have is that we have a system where we have discrete experimental data at a few locations. We have more boundary conditions than that. So we've been looking at ways of basically tuning boundary conditions, solving nonlinear system of equations to basically adjust boundary condition parameters to match the measurable data that we have. So that's one area of work. We've been implementing feedback control systems to be able to model, pressure receptor reflexes and things like that are important in controlling, cardiac function and pressure. And now, most recently, been doing patient-specific tissue properties and basically using inverse methods to infer properties from dynamic image data, and it's kind of work in progress. Just closing remarks. The techniques have really, they're really obviously. I have to say, I'm very I really feel honored to be here at this symposium. It's wonderful to see the story of computational fluid dynamics and to see some of the pioneers. It really is a pleasure. I think, I'm embarrassed to say, I think we're pretty early on in this field from a medical perspective, a cardiovascular perspective, but I think we have made some progress in recent years trying to develop better algorithms, and there's so many different opportunities to look at. The problems are very complex. Our first step is to really match some of the measurable data, the data that physicians care about. They could care less about shear stress, but they care about flow and pressure and quantities like that. My belief is if we can measure it, don't model it, but there really is a complementary benefit of imaging and computation. I think it's especially useful for extrapolating from measured data to conditions we can't measure, getting detailed hemodynamic data that we can't reliably measure, and then ultimately I think is using this as a tool to predict the future and predict outcomes of interventions, much as these tools are used to design engineering artifacts or structures. I think there's a lot of opportunity to use this in medicine. Thank you very much for your attention.